Good afternoon, everyone. Thank you, organizers. So, of course, the last topic will be from GU. This is gastrointestinal, because the outcome, the chronology is very well set, because this biliary tract has a very poor distal outcome, even if the best to best lines will have. So, not taking much of time. So just giving a brief, sometimes we just get confused what is intra, what is extrahepatic cholangiocarcinoma, and we sometimes don't even get to know what exactly the baseline or the root cause where it started. So we just start in the forms of biliary tract, so we label as a gross it's a biliary tract cancer, and sometimes even the primaries in the gallbladders, and we sometimes don't able to get the biopsies. So basically the incidence and the epidemiology of this biliary tract cancer are fluid and they are complex. And if you see, approximately 3% of all the GI malignancy, it is constituted by BTC. And this ISCC is this increasing, and this extrahepatic is decreasing internationally. So the etiology, not going to detail, and these are more common thing in our setup. Of course, the metabolic diabetes, mellitus, and obesity is one of the most important things to be taken care of. And again, in the gallbladder, cholelithiasis per se does not cause this, but it has seen that there is some of the association seen in this. And the parasitic infection, not common in our country, maybe in the China or Thailand, where this liver fluke or clonosis infection is some prevalent, they have these things. So the most important, again, the treatment approach, always the standard approach, if it is operable, we have to go for surgery and then the adjunct therapy accordingly. And if the patient is an inoperable candidate, we have to select for the systemic therapy. And variable approaches are there for different centers, like they are using any of the loco-regional therapies or the radiotherapy or some of the other photodynamic therapies. So first line, the standard of care, everybody is aware of this GEMSIS. This is the ABC02 trial. This is a standard line, and a decade back it came and it has shown a very good result. And in this, the overall survival was 11.7 months versus 8.1 months in the single arm gemcitabine with a hazard ratio of 0.64. The next is the GEM-CIS combination along with the nab-paclitaxel for the advanced. It was a phase 2 trial, and it has shown the again some response, but it was not into the practice of the combination of 3 drugs. So after this first line for the GEM-CIS or for the other gemcitabine-based therapy, we were not having any other drugs, and basically the prognosis or the outcome of the patients after the first line therapy is very dismal. We sometimes use the FOLFOX, all other therapies on the same. This was a trial which showed that the one of the drugs, that is durvalumab, which can be used with a combination of the GEM-CIS in the first line, and it was a phase 3 study. And the locally advanced or metastatic BTC were taken, and the patient were randomized into GEM-CIS combination, or along with the GEM-CIS, it's a durvalumab. So the primary objective of this trial was overall survival, with the secondary objectives were PFS and objective response rate and duration of the therapy. So demographic and baseline characteristics were well matched in both sides. The primary endpoint, if you see with the GEM-CIS and the durvalumab combination, is 12.8 months as compared to 11.5 months. It's a marginal difference, but the hazard ratio was 0.8. So it means little bit hard to justify at a very high cost how to add this durvalumab. And I have not seen any patient in my practice also which I even convinced for this durvalumab. So secondary endpoints, tumor response was again better on the patient who were receiving the durvalumab. That is 26.7% as compared to 18.7% in the GEM-CIS combination. So if you go with the subgroup analysis, if you see all the table in the hazard ratio is close to 0.8 or 0.9. So it favors that durvalumab combination in along with the combination of the GEM-CIS can be one of the therapies run day to day, means nowadays. But only it has to be challenged with a financial toxicity to the patient. So what after then we have progression following GEM-CIS or GEM-CIS durvalumab combination, single line therapy and beyond, and we don't have much of the therapies here. And we usually go for some of the NGS based panels or some of the PDL1 testing or MSA testing or TMB, which is a part of all the gastrointestinal tumors we are taking out, TMB and MSI. So these BTC, these all share a genomic alteration in the cell cycle regulations like CDK, N2B, and ARID1A mutations. And intrahepatic cholangiocarcinoma, they have FGFR mutations or IDH1 mutations or BRAF substitution with the MET amplification or with the KLORAS mutational frequency. And other pathways like PIK3, mTOR inhibitors, they were also commonly seen in the extrahepatic and the gallbladder tumors. So these are just graphs showing of all intrahepatic or extrahepatic or the gallbladder cancer, which all the tumors which we can see, and mostly if you see FGF are seen in the close to 10% patients, all these patients. So this was a trial in which this IDH1 mutation, it is showed that avascudanim in the patient with advanced cholangiocarcinoma, they have shown some survival benefit in the second line. And this patient, the median overall survival was 10.3 months as compared to 7.5 months in the placebo arm. So next was this pemigatinib. That was also again a phase 2 study, and it has shown that patients who had FGFR2 infusions or rearrangements, they have shown some response rate close to 36%, and the median duration of response was 9.1 months. And the responses was lasting for more than 6 months in approximately more than 60% patient, and close to 18% patient in more than 12 months. So next again, this BRAF inhibitors along with the MEK inhibitors, this gene has been found in approximately 5% of the patient, the BTC, and it has achieved a 51% response in patients with who are having this mutated cholangiocarcinoma. So this is a figure showing all these second line biomarker and the various trials and the various PFS OS survival benefit with these drugs. So if you go, this FGFR and IDH1 has shown some benefit as compared to the HER2 based. So the thing is this pemigatinib, again, it's not available with us. We have to get it from the outside, and the cost again is one of the issues when we are giving this to the patient. So this is a graph showing, table showing the other mutations can be endatinib or pembrolizumab or entrectinib. So these are all the second line therapies which we might confer to the patient, and they can have some outcome as compared to the placebo. So if we have done the this NGS panel, we don't have mutation, then what next? Again, we are again to this level, then we are concerned, how about immunotherapy? And always we are talking the IOs in all of these gastrointestinal cancers, like initially about the gastric, and again this pancreatic Vamsi I just told. So a lot of drugs are there, but again, there is no as such biomarker which can decide whether it's MSI high or TMB high, or we can use any CPS scoring. There is no such as compared to the BTC. So we have used the patient who have a high MSI or TMB in those patients. So this was one early studies, and this was basically the efficacy and safety of the pembrolizumab in the treatment of the advanced biliary cancer. The patient who have already received 2 or more than 2 lines. So in this, it has been seen that there is some sort of response to the patient who have the PD-L1 positive as compared to the PD-L1 negative. So if you see with this, these were both basically early phase studies, and they don't have any comparative arm in them. And in these studies, the exact tumor location was not available for some patients. And in this keynote 158, the overall response rate was 5.8%, with the PFS at 6 months was 11.4, and 12 months it's 5.2, and in the other it was the overall response was 13%. So it's just a marginal overall response rate if you compare with the just high-end drugs, and that too with having MSI high or other high TMB. So another study which is again for the refractory advanced biliary cancer tract patients, it's a phase 2 study for the nivolumab. And if you see the patient who received this nivolumab, the response rate is, means the overall response rate is close to PR is close to 10% of the patients as compared to the patient who, it is not basically comparison, means if the patient does not receive any, means we don't have any options for the patient who had advanced biliary refractory cancer tract. So nivolumab can provide modest, but it's a durable clinical efficacy with a manageable safety profile with a patient who are basically refractory to other first line or second line chemotherapy. And when we don't have any option and patient is still having good performance, you can offer. So to conclude, this is the latest guidelines from the NCCN. If you see, the first line still remains the GEMSIS combination along with the durvalumab, and the second line combination can be chosen whatever the therapies you have. If there is no mutation, you can go with the FOLFOX. And if the patient is having high MSI or TMB, you can give the immunotherapy in those. But otherwise, the prognosis in these patients remains dismal. So to conclude, despite the advances in this cholangiocarcinoma made in the last decade, the prognosis still remains poor for the locally advanced or metastatic. And the mutation discovery of this mutation in IDH1, FGFR2, HER2, BRAF, NTRK as well as subgroups of the PDL expression and the high MSI or TMB has revealed the fields, but still we are not able to give the good results. And second line and beyond treatment option may give some response in patient with the target mutation. Thanks.
Thank you so much, sir. Any questions for the? So it is difficult to treat, sir, metastatic GB in the refractory cases. There are the few options are there, and in without metastatic also, if it is recurrent GB, then it is also difficult. We all know about the difficulties. So for this, they are the conclusion of the GI with the all the colorectal and then the pancreatobiliary and new therapies, immunotherapies in gastric and esophagus also. Thank you so much, sir.
Thank you, sir.
And now for the organizers for GU cancer session.
Can I have one question? One question. As you have mentioned, there is hardly any benefit of use of durvalumab in the Topaz 1 study.
So if you see, the hazard ratio is 0.8 and the difference is hardly 1 month. It's a 12.5 versus 11.3. So
I'm coming to that. So, but if you look at the tail of the curves of the two, so what typically happens is around 25% of the patients will be alive at the end of 2 years if the patient is on durvalumab. So it is something which is probably not what we normally see in practice. If I tell my patient that there is a 1/4 chance, 1 in 4 patient might survive for 2 years, do you think this is a good enough reason to consider durvalumab?
Presently, I don't think. Whatever you have pointed out, maybe once we have seen with the patient with the colorectal cancer, we are given immunotherapy. So we can switch from the 2 weekly to or 3 weekly to we can switch from to the longer durations. So some of the effects is still maintained. Maybe that can be explained. Possibly I don't have reason.
So typically there will always be few patients who might be sitting on the 10. And that is something which we don't know since we don't have a biomarker.
Yes. But the thing
that is something which of course the time will decide. But then there is some hint that something is happening good for a certain set of patients, just that we don't know which patient.
Yes, I do agree. But at the financial toxicity is very durvalumab is very costly. And I think majority of the patient, if you tell the prognosis and outcomes, they will not be easily convinced for the durvalumab.
But sir, this is a good therapy for the, if there is a chances of there for the response to durvalumab, it will be long lasting for these patients.
Maybe with more of the time, we'll have a better idea. So
because the end curve is the more separating than the chemotherapy alone. Thank you, sir. Thank you so much.
Thank you so much.
Thank you, Dr. Jagdeep, for excellent session. And Dr. Nikhil, very good point that about the Topaz. And we respect and we know that subset of patients will always do good. And when we discuss the science, the economics remains the secondary things. And probably we all want to learn more of science and less of economics. And it's a good point. Thank you so much.